Our speaker is a surgeon, lecturer, and clinical entrepreneur who drew on her passion for innovation, education, and global surgery to found Proximie, an augmented reality platform that allows doctors to virtually transport themselves into any operating room anywhere in the world. Dubbed the future of surgery by CNN, Proximie has won multiple awards, as well as being the main focus of the Foreign Press Association's Science Story of the Year. It is revolutionizing the delivery and education of healthcare by ensuring that every patient gets the best care in the world, the first time, everywhere. She joins us from London, so let's have a global welcome for Dr. Nadine Hachach-Haram.
Hi, everyone.
Hi there. Say, Nadine, are you going to be showing any slides or?
Yeah, I think you need to just enable.
Yeah, I'm going to mute everybody. I'm going to unmute you, and then I'll give you the host rights.
Thank you. It's great to be here. Thank you for the. And I'm quite impressed that there's so many people online. I think I see 56 participants so far, so that's pretty exciting. Amazing. I do live in London, but whilst I'm being made host, I actually grew up in San Diego, California, but I've been now in London for the last 18 years, so I consider myself, a bit of both. But here we go. Can you see my slides?
Yes.
Fantastic. So hopefully what I'll share with you is my passion and mission to think about how we scale surgical excellence, surgical expertise, and how I've, in my journey, really tried to leverage technology to address that challenge, and looking at solutions like telecommunications, augmented reality, and artificial intelligence. But to give you a bit about my background, I'm a practicing plastics and reconstructive surgeon. Mainly my clinical practice is focused around breast and pelvic cancer reconstruction. And I work here in the National Health Service at one of the larger hospitals called Guy's and St. Thomas's, which is just across the way from Big Ben. And we had the pleasure of looking after the Prime Minister when he was ill with COVID a few weeks ago. What's interesting as well is in my role at that hospital is that I'm also the clinical lead for innovation. So really thinking about how on the front line we embrace and empower ourselves to look at technologies and solutions that can help us deliver the best care to our patients. And over the last 5 to 6 years, I've really developed what one would say is more of a portfolio clinical career, where I've really focused on looking at technology, innovation, and solutions that are going to make us think about what the next 5, 10, and 15 years are going to look like in surgery. And I've had the honor of being involved in a number of activities globally, including things like ExpoMed and Singularity out in the US, and speaking at TED. But really why I decided to become an entrepreneur was because of something I was facing on the front line. So as a practicing surgeon, I'd spent the last 10 years traveling the world working with global charities. I'd worked with device companies to train and empower new surgeons to pick up new skills and new devices. And across the board, I witnessed that there was a huge issue around variation in care. And I wanted to think about how we could combine the best of human expertise and the latest technology to try and ensure that every patient everywhere in the world could get the best care the first time, every time. And when I started to talk about this mission, a lot of people felt that this was really a global health issue. So this is really, I would get the feedback, well, this is really an issue for the poor countries or the developing nations or areas in Africa or areas in Asia. And I tried to make it clear initially through words, and thankfully some studies and publications came out that really referenced that, which identified that really variation in care is a global issue. And it is an issue in our world, in the Western world, as much as it is globally. And I put these numbers out there really to highlight some really key markers that are happening in our own healthcare systems. So here, for example, in the UK, you are 14 times more likely to die of colorectal surgery between one hospital and another. In Germany, you're 9 times more likely to suffer complications from vascular surgery between one hospital and another. Equally, in Sweden, you're 36 times more likely to suffer from cataract surgery between one institution and another. And these numbers are really significant when you think about the lives impacted and affected by this. And these are not numbers from poor countries. These are high-income Western countries that are suffering from this issue around variation. And so it really kind of resonated when you look at what Barry Rosenberg said, is that quite simply where you live determines if you live, is very much what we're experiencing, that kind of postcode lottery. And it's fair to say that as much as that there's a human impact for this, there's equally a financial impact. And we've seen in the UK, for example, $5 billion are spent managing this issue. And in the US, it's around 20 billion. So it's a big, big issue with a huge human and financial impact. But if we take a step back into history and we look at surgery, this is really how surgery was shared. It was very much about collaboration, discussion, viewing, learning from each other. And these are pictures from Mass Gen and from the early days in some US hospitals. But very much this idea of that collaboration, and probably the word operation or operating theater, which is what we use here for the OR, is very much about that kind of approach, that amphitheater approach to surgery, which was historical. And this picture, whilst it's facetious, it really kind of highlights where we are today. And I see this, a lot of times, not to this extent, but definitely in RORs, we see a lot of people trying to come in to see our, first in kind, first in time cases. And you think about, I'm not training now just this small group of surgeons. I need to be training that and exponentially that many more. So how are we going to scale every single surgeon who's doing things very well to everyone else in the world? And how can we then support doctors and surgeons through coaching and mentoring through that? And it's interesting, we're doing a current project where we're trying to compare quarterback coaching and videoing and support with surgical coaching and mentoring and support. But also just to highlight a bit of the problem, we see that as we're seeing a huge rise in an aging population, we also have a growing deficit. So we don't have enough surgeons with the expertise to deliver all the care that is needed to all the areas in the world that we want it to be delivered. And these are, again, just numbers from the US industry that shows that there's going to be a deficit of about 100,000 US surgeons, by 2030. And probably now with COVID and everything that's happening, we're already seeing the health system sort of breaking at the edges. And what's happening in conjunction with that is that we're seeing a huge surge in new devices coming to the market. Every other day we hear about a new robot, a new cardiac clip, a new device that we need to be trained on and we need to deliver care to our patients with. And how are we going to do this safely and effectively and at scale? And so as I started to think about these problems, there was a number of technologies that jumped out at me. Things like real-time connectivity, things like augmented reality. How do we combine the real world and the digital world together into an environment that's going to enable us to do better or to scale the care that we want to in a more effective way? And then how do we learn from those unique insights through artificial intelligence and machine learning, not for the sake of an academic exercise, but actually how can we then derive insights from that to improve and do better? And at the heart of what we do, and I think which is why it's really important that whilst I'm looking at innovation, I'm coming at it very much with my clinical hat on as a practicing clinician, it's very around value. And Michael Porter and Harvard did excellent work looking at how do we measure clinical value? How do we measure value in a health system? And it's very much around looking at sort of two key levers, which are outcomes and costs. So how can we improve outcomes and how can we try and reduce costs? And ultimately, if we can get both, that's even the best scenario. But if at least we can get one of them to improve that value, then that's definitely a win for health systems. And so bearing in mind all those things I talked about, I also started to think about how we're going to do this today. There's an element of an urgency as well as a pragmatism that needs to come along with this. It's very easy to come up with this sort of blue sky thinking solutions that need a lot of internet, very cost prohibitive, not necessarily scalable, don't fit in with things around behaviors of surgeons or behaviors of practice, and that would need too much of a change that would make it impractical or not achievable. So I was trying to come across how can we bring in these solutions that are going to actually, as adjuncts to what we do within our healthcare system, to increase quick adoption and hopefully increase the care and the value that we're going to bring to our patients. And so with that in mind, I looked around, couldn't find a solution that would solve that, and so developed my own solution. Of course, I'm not an engineer myself. I had some members of the team work on that, but I wanted to develop a platform that could aggregate the surgical community to enable collaboration in real time. I wanted to allow surgeons to virtually scrub into operating rooms and procedure rooms and assessment rooms anywhere in the world to visually and practically collaborate and to share best practice. I wanted the solution to allow the sharing of expertise in a secure and scalable way. And I wanted this solution to allow us to aggregate data sets for unique insights in the future. all-encompassing, knowing that doctors who collaborate together improve and reduce variation in surgical care. And so Proximie really is broken down into two main components. And on the TED Talk, for those who may have seen it, really you see this component. I'll talk through the second component. But ultimately, I need to, with low bandwidth, low latency, be able to virtually scrub into any operating room. And you can see there I have a feed of the operating room or the operative field, and I can virtually point in and put my hand into that field and annotate, guide the doctor, move through what steps need to happen, and sequentially help doctors work through steps as they're doing it in real time. I may also want to see the view of the room, and I may also want to see other views, and we take up to 4 views within that environment, and we layer augmented reality onto that. We do this in a way that requires very low bandwidth, and the proof you'll see in the cases that we've done have been in very stress-tested environments, including war zones and including difficult low internet areas. And every single interaction is tagged and stored into a library, so you can come back and review that for improved performance. Because ultimately, as in the same way as athletes, we know that by reviewing your performance and even just viewing it yourself, you'll be able to see areas for improvement, let alone having your mentors and your coaches guide you through that. And I'll probably just highlight an article Atul Gawande wrote, for those of you that know him. He's obviously an avid book writer, but he also wrote a really interesting article in the New Yorker a few years ago where he talked about surgical coaching. And he said that in the same way that athletes have coaches, they're at the top of their game, you know, tennis players, football players, soccer players, they have coaches. And so why shouldn't surgeons have coaches as well? And why shouldn't we have a mentee-mentor element within surgery where we support each other? And could that be done in different ways beyond just the physical presence in an OR? And so to date, Proximie has been used in over 30 countries. We support over 300 cases every month, and we're growing very quickly now with ramp-ups to sort of 500 and 1,000 by Q3 and Q4. And what I love about this technology, it is the same solution that is helping first world countries like the UK and the US do cases. It is also helping countries like Ethiopia and Vietnam also deliver care to their patients. I'll give you one example. We have a surgeon in Chicago who uses it for her ENT head and neck team within her department, but also in her free time, she dials into Ethiopia and helps healthcare workers to manage ear assessments. And it is that team here in this picture. And so it's really about democratizing access to expertise and sharing best practice. I'll show you some videos, I think, which will help demonstrate this further. I apologize for those who can't see. I mean, this is bowel, so hopefully you won't really see any blood, but just give you a warning there. And just to give you a bit of context for this case, so this is an expert in Amsterdam who's got a technique around low rectal cancer resection. And he's able to, sitting at his desktop, you'll see a screen grab of his desktop, he's able to dial in virtually into the operating room in Wales, in Cardiff. And he's able to talk through with the surgeon the techniques that he would employ to try and have a better, you know, little tips and tricks that are going to give him a better chance of getting a better outcome for this patient. And you'll get to see the mirror view of both. So you'll see here, it's a screen grab of his desktop. He's able to see the laparoscopic instruments. He's also able to see the room where the team is sitting. And he's also able to link in content from Elsevier. We're partnered in with Elsevier's digital content. And this is one of our old views. Obviously, our newer interface is much newer, much fresher, but you get an idea of the solution.
So you've got that's it. Good job. That's a new one.
And all he's using is a webcam attached to his laptop, and he's able to put his hand in and sort of talk through the case. And the receiving surgeon is seeing it now, as you'll see.
Yeah, so that if the patient is twisted in a left-sided position, that you know where 6 o'clock is. Just mark 6 o'clock and then you come to that stage. So you've got yeah, that's it. That's a new one.
So this is a software-only solution, so we're able to just tap into the hardware, the ancillary cameras and others already, and screens within the OR, and we're able to leverage that solution with very little, if any, latency. We're also able to bring in multiple feeds. So we do a lot of cases with the big cardiology companies, helping them scale catheter procedures within cardiology labs. But also we do a lot of training. And so we're able to take real life patients and overlay information and anatomical images and talk through, you know, the steps of a procedure, the anatomical steps and landmarks that one should pay attention to. We're able to bring in ultrasound, and these are cases where we work with urologists on cystoscopy and ultrasonography. And we're able to now combine the paradigm of all. So what Proximie has now gone to, this is the next level, where we're able to bring together telecommunications, augmented reality, as well as artificial intelligence. And so we've deployed this across colonoscopy suites in Wales, where we're able to support each other through training and upskilling of endoscopists, but also give them some tips through AI, as you can see here. And that's really the future of bringing together that paradigm shift of multiple technologies together. Of course, you know, what continues to give us pleasure is that we are continuing to pass multiple tests that give confidence in our product. So Proximie recently won a tender with the UK military. We were up against a lot of the big players when it comes to security, compliance, the architecture, the infrastructure, and the scalability of our solution. And we were successful in that multi-year tender. And as you can see, it's very simple. All we need is a simple webcam. This is a field hospital in Oman with the UK military, and they're able to stream that back to their camp base in Birmingham and discuss through that case. And as I said, we work now with in over 30 countries. We've worked with 21 medical device companies, doing over 300 cases a month and due to scale. But also we care about the academic aspect of it as well. And even just in the last month, we've had 4 articles accepted for peer-reviewed journals. I also think it's important to think about how we're adding benefit to the carbon footprint globally. And so we also collect on a quarterly basis how much travel we're saving by having doctors working remotely, medical device companies supporting their teams remotely, and not needing doctors to travel all over the world to learn from each other. And so just in Q4, we saved about 660,000 miles of travel. I imagine already just from seeing our numbers in Q1 and Q2, that is going to be significantly higher, especially with travel restrictions. And I wanted to very briefly also talk about, you know, what we're seeing in the COVID phase, which may be relevant now, and that we've seen really kind of 3 distinct phases emerge: that kind of urgent emergent phase, the re-engagement phase, and the reboot phase, where the urgent emergent, hopefully at least here in the UK, we're starting to see the tail of that, where it was that immediate real-time support. How are we going to get people to help each other during this emergency environment? But now we're starting to think about how are we going to, you know, re-engage displaced clinicians post-COVID? How are we going to start operating again? What are our pathways going to look like? How are we going to reduce people in the OR because we want to limit infection control and support through that? And ultimately, how are we going to reboot and manage all the backlog of procedures with sufficient expertise? A lot of people have also lost a bit of confidence with the de-skilling and just the emotional toll that this has taken on all of us. And knowing that in the first few cases, we can have colleagues dial in and give us that emotional and kind of support through that case, I think is going to be really critical. But in that emergent phase, Proximie was deployed to support orthopedics and trauma, helping self-isolating doctors support their junior colleagues on the ground. We were there to support cath labs for cardiac cases. So just last week, for example, there was a life-saving operation that needed to happen where we were able to support through that. And ultimately working in kind of triaging clinics, supporting reps not being able to travel to help their doctors do cases, and ultimately think about how we support intensive care doctors on the ground. And we've been working with intensive care units here in the UK to deploy a connected ICU, an eICU, which is managed virtually simply on tablets, where doctors and nurses and pharmacists can work together. I could spend hours talking about Proximie, but I'm conscious that this is you know, your meeting and I'm a guest here, so I've tried to keep it brief. But I'm happy to take any questions if there are any, but otherwise, thank you for listening. It's great.
I'm sure there will be questions, so unmute yourself and ask away.
Hey, Nadine, Buddy here. Got a quick one for you.
Yeah.
Do you see incorporating this into the universities, the teaching hospitals? Because my background is aviation, and when we went to simulation for training and for evaluations, the safety record just skyrocketed off the charts. And I see this, do you see this as a valuable tool in that regard?
Absolutely. I think one of the slides, which I didn't share here, is very much, so surgery has always been a see one, do one, teach one. If anyone is in healthcare, they've probably heard that mantra. And that's really how we've been trained in surgery: see one, do one, teach one. And then we moved a lot into the simulation, which even in surgery, like lap simulators for laparoscopic cases and others, made a big instrumental change in how we deliver care. And I think ultimately that was derived from the aviation industry, and we still reference the aviation industry. But now it's like, how do we take it to that next level? And I guess to some extent, again, aviation plays a big role, where you think about black box and how do you go back and review performance, and how can we learn from recordings of cases. And so proximity to some extent can play a bit of a role in that. And we see, I see very much us moving from that see one, do one, teach one, to very much how do we prepare, how do we perform, and how do we perfect our skills. And so the prepare bit is the simulation bit, and the perform and the perfect bit is something like this, where you think about how do we bring this into real-time OR, and how do we then go back and review, like the black box, but like others, actually our performance, and how do we see how we can do better and learn from those. Every single experience is a learning opportunity.
Nadine, I have a question, if I might. I don't think it's any great surprise that we have a shortage of physicians worldwide. Does this in any way take care of the issue of inadequate numbers of brick and mortar medical teaching institutions and the possible proliferation and growth of physicians that are needed everywhere?
I think that's a really great point. And I think part of the problem has been subspecialization. I mean, that's a good thing, right? You'd rather have your expert in knee operations as opposed to your generalist orthopedic surgeon. Same with plastics. We subspecialized in breast, hands, skin. And that was done for a reason, because you wanted people who were doing enough of that specific case to be the experts within it. But of course, with that and with centralization of care into certain big teaching centers come the consequences of de-skilling in the peripheries and lack of access at the peripheries. And we've been having a lot of discussions with institutions like the big ones, like MD Anderson and Cleveland Clinic and others, saying, why does your expertise, or you're a center of excellence, why does your expertise have to be limited to the four walls of your building? Could you imagine a virtual MD Anderson, where actually MD Anderson could then tap in and dial into every center that needed an MD Anderson, or a Cleveland Clinic, or a Harvard? There's a number of institutions that each have expertise in a specific thing. And could you not virtually deliver that to every peripheral hospital? And we're doing a lot of work now with medical device companies to drive that value-based healthcare through digital solutions. But it's, we're at the start of it. Definitely COVID has made it less, has decreased the friction and has accelerated behavior change. So it's exciting time from that point of view.
Thank you.
Nadine, I put a quick question in the chat. If you're familiar with the concept of One Health, which is the collaboration between human and animal doctors, and the fact that to a stunning degree, pretty much every medical issue that humans experience, animals do experience in kind of a paralleled manner. Do you see a collaboration between human surgeons and veterinary surgeons here for this use?
I think it's a great question, because only 3 weeks ago we were asked to give a big presentation to the board of Viticus. Is that what it's called? Viticus, and is it near Vegas, which is a human veterinary health center for training. They do both. So definitely we're on that path. And a lot of members of my team have been pushing me for the last year or two to look at veterinary medicine. So yeah, definitely.
Thank you.
Nadine, this is Pat. My question has to do with off-site robotic surgery. Do you think you will be developing that as well with your techniques?
So what our solution does is today is already links into robotic devices. So like a Da Vinci robot or any of the other robots that are on the market, we can feed our solution or software into it. And so while you're in the robot, you're able to see the proximity telementoring solution and have that guidance going through. I think in the future, definitely, I'm sure some of you are aware, years ago at Strasbourg, they tried to do the remote robotic where someone could be sitting in one country remotely managing a robot distally. And the military have looked at that as well. And I think there were challenges around latency and issues with that. But I think with 5G and other connectivity solutions, that may change in the coming few years. So it's definitely something that we've been asked to look at as well. And a lot of these opportunities we see as collaborative opportunities as opposed to us trying to solve everything. So already having conversations, for example, with the AI surgical sensors at Harvard and MIT, and I think a lot of these things will develop from that as well.
Nadine, this is Conrad Brees. The question I have is 50 years ago when I started college, they were talking about the impending shortage of surgeons. We have a friend now that's in her 8th year as trauma surgery. Doctors have in the US kept down the number of medical schools, they kept down the number of people. They insist upon training surgeons so that they work 48 hours straight. And this woman is telling us about this experience. I see nothing changing at all because the pressure from the doctors not to change the system is the problem.
I think that was probably the case, definitely a couple of years ago, but I think at least here in the UK, and I hear from my colleagues in the US that there has to be a way to change this because one, you're going to get burnout very quickly. Two, the health systems, that's where mistakes happen. That's where people are tired. They're operating, after a 40-hour shift. And that's where solutions like this and many others can play a role to support each other through that, to support each other through mentoring and coaching, having someone with a fresh pair of eyes. I've had surgeons talk to me from, neurosurgery who say, sometimes after a long 12-hour, life-saving case, you're tired and trying to make decisions on your own can be really harrowing. But being able to have another colleague dial in and share that stress with you and think about how you make decisions and support you can mean the world, and we've done many cases in those environments where, they don't necessarily need to have the, just like that case I showed you in Cardiff. That surgeon in Cardiff is very skilled. He doesn't necessarily need to have the surgeon remotely dial in, but knowing that he could, and they could talk about cases and support each other through it, played a role. I think there's obviously wider legislation issues that I'm not totally privy to in the US, but definitely around hours of working. We've made a lot of strides here in the UK, and that's limited to 48 hours a week for surgeons now. So that's a huge win here, but definitely in the US, I know they work long hours just for my friends in surgery.
Right.
Thank you.
Don Jenkins here. Is there any reason that this is not being picked up as a public corporation? Or I just can't understand why there would be the resistance other than what Conrad says. Why is money the thing that keeps this from going bigger, or what are the obstacles?
We've been going for a couple of years. Initially, we focused, we wanted to test the pathways in the environment. How do we get this? As good as the technology is, it's how quickly can you implement this within health systems? How quickly can it get adopted? How do you go through IT and, that bit? And so very early on, we focused in kind of one area. So I started off in Europe within my health system because I knew kind of how to navigate it. And then, this year I would say we've pushed in the US, and just in the last month, we've seen huge interest in it. So I think the scale is not at all about money. This is cloud-based. It's fairly inexpensive. It's very much more about just educating people about it and making them know that it's it's available. So we're doing a lot of work now with societies and associations like SAGES, and we're reaching out to the American College of Surgeons and a number of other groups to see how they can also help in championing that. And I think the device companies have also played a role in that. So every time we partner with a device company, they put us in anywhere from 15 to 35 hospitals, and that helps us grow quickly. So we're in over 60, 70 hospitals now, and looking to grow. We are, as I said, we're a small team. We're about 40 people, and we've raised our Series A recently, and we're now looking really to scale that even more.
So how do you make money? What's the structure?
So we have adopted a B2B business model. So we sell licenses to device companies so that you can use it for their proctorship and preceptorship programs and their professional education to allow them to then deploy into hospitals. And we also partner with hospitals on an annual kind of like a SaaS model where they use it as a software to help them deliver better care, better training and solutions. But it's fairly inexpensive, and I've tried to keep it that way because I'm conscious of with my clinical hat on that, things that are big and bulky and have a big capital, expenditure ticket to it makes it very hard for these things to scale. I think it's also probably worth mentioning that we partner with charities for free. So for us, it's about making sure that charities are supported to help wherever possible. And we like to partner with surgical societies and associations to help them help their training committees as well.
So how do you do compensation? If I'm a physician here in the Bay Area and I need assistance, and you're a physician in the UK who's going to help me, how do I compensate both physicians?
That's a great question. So which is why we started first in Europe. So here in the NHS, that model of compensation doesn't necessarily exist because it's a one health system. In the US, there are CPT codes and reimbursement codes for that. And we recently hired a guy by the name of Tommy Flashens. His PhD was on surgical telementoring, and he works with all the policy groups with AdvaMed and the telemedicine societies. And they have identified clear reimbursement codes that people can claim as second surgeon or second assistant on these cases that can allow them to generate income from those cases.
Yeah, this is Rich Shearer. I'd like to go to the more the technical side now. You're talking about having people in remote locations, war zones, that kind of thing. What is required to hook in from those kind of locations? I mean, we all have our internet access of one form or another. What is the minimum that folks have to have in the world in order to tie into your system?
Yeah, no, it's a great question. So for me, the biggest criteria was actually the bandwidth and the bandwidth adaptability. So it had to work on low bandwidth. So today, Proximie has been even done on 4G hotspots in areas, off mobile phones. You need about, at the most minimum, I think probably about 4 megabits per second. So that's, fairly achievable even in those countries. So we've done it, as I said, in war zones. We've done it off naval ships. We've done it in Kabul and Afghanistan and the Middle East, and really stress tested it, and it's worked on a 4G hotspot absolutely fine. And we've also gone to the other extreme, which is, trying it on 5G where you have unlimited bandwidth, and, it's worked fine. And in our system, we've made it work so that it adapts to the bandwidth. So if you are running, 4 feeds on, HD, that's going to require a higher amount of bandwidth. And as you're working in areas where the bandwidth drops, it warns you and it tries to drop the feeds to 1 or 2, and then it changes it from like an HD to a 1080 to 720. So we've tried to build fail-proof mechanisms into the system to adapt to that situation.
Do you experience resistance from doctors who, because of their egos, are reluctant to bring in outside consultants?
Not so much, because the way we've presented it, and I say this with me being a surgeon as well, is that it's very much about collaboration. So there's no, I'm the expert, you're the novice, I'm going to tell you how to do things. It's very much about sharing ideas and sharing best practice and learning from each other and discussing interesting cases. And so that approach it definitely wins. And I think secondly, if they are the type of surgeons with those particular egos, and I can say it because I work with surgeons like that, and probably some may say I'm one of those, but ultimately we pitch the idea to them that they're sharing their practice with everyone, and everyone should benefit from learning from them. So it's got a very benign approach to it. So that's kind of, yeah.
More questions?
I have a question on that, just following up on that point. If you have 2 surgeons or 3 surgeons or 4 surgeons that are participating virtually in a surgery, is there some protocol for determining who has the final call on a decision about how to do this procedure?
It's a great question. And I think that very much fits into what we need. We needed to almost bake into the process the terms of engagement, because the challenge then becomes, who's in charge and who's going to actually lead this case, and where do all these decisions sit. So the way we've set it up, and we've spent a lot of time with actually, medical legal teams and structured end user license agreements around this, was that ultimately the doctor who's in the procedure room, whose hands are on the patient, is responsible. And this is no different to how it is today. I mean, I could sit in the coffee room today and get advice from a colleague, and then I can go into the OR and do the procedure however way I want. I can decide to take his advice or not, but ultimately it's me whose hands are on the patient, so I am responsible. And so within that setting of 2, 3, 4 people giving advice, it's very much given as advice. And ultimately it's the doctor who's in the OR who needs to decide what of that advice he wants to take and what of it he wants to implement.
Anyone else?
I have one other follow-up question on that. As a lawyer who has represented medical device companies for 40 years, it seems to me that you're obviously generating a record of the surgery, video record of the surgery, which ultimately could be used and obtained through discovery if necessary. Have you thought of that?
Yeah, so the way we've worked with hospitals, so we've worked very hard to ensure that we are HIPAA and GDPR compliant. We've also worked with hospitals around data servicing agreements where it's the hospitals that own the videos. So the responsibility around those videos sits with the hospital and not with the company itself. So we don't own the videos, we don't own the content of the videos, it's the hospital and the kind of the clinician body within that hospital. So then it goes back to the hospitals themselves in terms of, you know, how they produce that. We don't save any patient identifiable data, so you wouldn't actually be able to go back and say this is the bowel, you know, surgery of, you know, Matt Ginn, for example. But definitely we've worked through that and worked through processes that has been approved with every hospital that we've gone through data protection and gone through the DPIAs through that. And we've also, on the subject of medical device companies, have also sat with all the medical legal teams of at least the top 5 blue chip companies and a lot of the mid caps as well. And it has been above board from that point of view as well. But again, I'm not the medical legal expert, but we have medical legal teams that advise us and sit on our committees. That's a great question.
Oh, hi Nadine, Buddy again. I got another question. Does the performing surgeon have access to that recorded video so he or she can go back and review what they've done and say, man, I wish I'd done this, I could do it better, da, 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 da. And the way we did that in aviation is you're granted immunity if someone tries to do that. And it's a fabulous system that just helps safety. And by the way, I just sent you an email with a nice thank you certificate about, which they're going to tell you about in a minute.
Thank you very much. Thank you.
And Nadine, one last question. What kind of reception have you received from your colleagues?
I have to say it's been incredibly positive. My colleagues and also nationally here in the UK, I mean, last year or kind of just towards the end of the year before and early last year, I was very lucky to be given the Queen's Birthday Honours. So I was given the British Empire Medal for services to healthcare and innovation. And from that have been really recognized, at least within this health system, but definitely within the innovation groups within the US, like exponential medicine and Singularity, as a pioneer in some of the solutions that we're doing. So I'm proud from that point of view, in that, you know, I'm a female surgeon doing that, so that makes me proud, and also a kind of a frontline doctor trying to make changes within our health system is also very positive, I think.